We are proud to launch MedikaTalks, an exclusive healthcare-specific knowledge-sharing and conversation platform, powered by us to facilitate a deeper understanding of the entire healthcare domain, be it challenges, opportunities, past lessons or future endeavors. Our vision with this platform is to cover most important topics regarding the industry, and then gradually zoom out to create an entire knowledge warehouse. This knowledge management platform will be built on strong, tested and implementable opinions from esteemed experts of the industry. We will be conducting regular sessions in the form of webinars, expert talk sessions, CMEs, CXO meets and more where industry leaders rich in experience can share their diverse and deep knowledge for the benefit of the entire community. Thanks for tuning in. Hope you would find this interesting and insightful.
This is Dr. Akash Rajpal here from Medikabazaar. I'm the Executive Vice President at Medikabazaar, and I thank the Confederation of Indian Industries and Joy to have given me an opportunity to moderate this esteemed panel. Today in this panel, we will have a keynote address on the changing scenario of innovations in oncology like HIPEC from Joy Chakravarti, who is CEO at Hinduja Hospital. Then we will have Dr. Yuvraj joining in from Kokilaben Hospital, who runs the HIVEC program there. We have Dr. M.D. Ray from the All India Institute of Medical Sciences. We have Dr. Narendra, all the way from Tirupati, and Dr. Robin, who will be joining in sometime. Dr. Ninad, unfortunately, can't join in due to some emergency. But I would now request Joy to start with his keynote address. Over to you, Joy.
Thank you, Akash, and thank you very much for moderating this session. And I want to thank on behalf of CII and personnel to all the panelists who are present here, and special thanks to Medikabazaar for joining hands with CII in organizing this session. So as I see the topic which has been selected, that the newer modalities and popular protocols in oncology. It is a very pertinent and very important topic. That is not because all of us need to know about it, but we know that in India, the way the growth of oncology, onco patients are happening, we need to fight with this big C in multiple ways. And some of these, we have seen the evolution of oncology treatment over last 2-3 decades, and there is definitely a significant change which has taken place in this overall approach. To begin with, patients were traditionally going for chemotherapy, some cases surgery, but with the advancement of different surgical branches, the things have become much sophisticated, and experts with suitable training are now taking control of the situation. We have radiation therapy, PET CT, all of us, we know about all this. But there are a lot more to come, because when somebody is affected with cancer, somebody is diagnosed with cancer, from there till many cases they die prematurely, and in many cases the quality of life gets deteriorated over a period of time. So I'm happy that we have so many experts from the field who are going to talk about these newer modalities and protocol. At the same time, we know the kind of molecular biology or other techniques which are coming up in terms of prediction, at the same time, in many cases, early detection. So these are also helping us in significant way to fight against this menace. I want to also mention about what Akash mentioned about high-tech kind of technologies, which are going to be path-breaking, which are going to contribute significantly, I'm sure, and the results are already coming. And we know that it is a matter of time when we will see newer protocols will adopt all these technologies more significant way. And I'm sure next time we meet, at that time we will have many more in the pipeline. Ultimately, all of us have the same aim and same goal to fight against this kind of life-threatening diseases. And finally, I want to tell this is an endeavor of CII Western region to ensure that what kind of contribution you are making in the technology front, and we have come out with a, CII Health Tech 2020 a program where between 24th to 29th of September we are going to have conferences, and for 14 days there is going to be virtual exhibition. So those who have joined here today, those who are attending today, please make benefit out of it. The participation is completely free, but you are going to get country participation like UK, Israel, and Netherlands. So there will be a lot of new technologies which will be projected, presented, and exhibited. So please make use of that virtual platform. And I'm sure I'll not take much time from now, and I'll hand over to Akash for a very interesting discussion which is going to come up now. Over to Akash.
Thank you, Joy, and thank you for kickstarting this. The whole idea behind this particular panel discussion was that when we hear the word cancer, everybody talks about radical, surgeries, etc. But a lot of newer innovations have come in, like HIPEC, HIVEC. A lot of people here in the esteemed panel are going to talk about it, how it is changing the entire scenario in this country through various innovation methods which are coming in. My first question now is going out to Dr. Narendra. He is from the SVIMS Tirupati. He's the professor and HOD of surgical oncology there. Dr. Narendra, welcome. I had witnessed your amazing event in Tirupati just before the lockdown. It was just like a national event, and congratulations to you on that. My first question to you is, Dr. Narendra, is can you tell more about what this HIPEC is? Can you give some broad concepts? And can you just give in very short brief to our audience out here as to what we are talking about, so then we can take this discussion a little further.
Thank you, Dr. Akash, for kind introduction. So HIPEC is the acronym for Hyperthermic Intraperitoneal Chemotherapy, which is nothing but delivery of heated chemotherapeutic drug in higher concentration into the abdominal cavity. So this is a newer modality of treatment, usually follows a surgery what is called as debulking surgery or cytoreductive surgery, where majority of the visible disease is removed, followed by in order to treat some of the cancer cells which cannot be seen, we deliver through the help of a special equipment called HIPEC machine. We deliver chemotherapeutic drugs in larger concentration, which cannot be usually given by intravenous route. Such doses cannot be given. That can be given, and simultaneously the chemotherapy drug is heated to a temperature of 41 to 43 degrees centigrade. So what happens is, not only the local concentration of the drug is very high, the heat itself causes death of many cancer cells. It also drives chemotherapy drug into cancer cells in order to achieve a very good response. And some of the cancers, common cancers where it is being employed are like advanced carcinoma of ovary, pseudomyxoma peritoneal cancers, primary cancers, and colorectal cancers which have spread to the peritoneum. So all these cancers patients do well with this type of treatment. Thank you, Dr. Akash. Over to you.
Thank you, Dr. Narendra. So, it's for the audience, this HIPEC is, and similarly HIVEC, is a very interesting concept. The scientists and the researchers found that if you heat your chemotherapy at a particular temperature and then you use it on the patient, then the permeability of that agent, the chemotherapy agent, into the body is much faster. So in a very broad, crude sense, the amount of chemotherapy which you require into the patient is technically less. So the toxic effects are less, and the treatment outcomes are much better. So in a broad sense, this is how it is. My next question is to Dr. M.D. Ray. He's the additional professor at All India Institute of Medical Sciences. Thank you so much for joining us today, Dr. Ray. I have a question for you. You are in the government sector, right? So how is the government hospital facing the challenges for the CRS HIPEC, and what are you doing to overcome all these challenges? We'll come back again to the other panelists to discuss more about these new modalities. But I'm always interested to know how government addresses a lot of administrative challenges around these things.
Thank you, Dr. Akash. Actually, to tell the truth, our life itself is a challenge, The shares, I think, is a small stake in compared to that. So that there are some limitation is there. And anything we do, some limitation is everywhere is there. Like in government hospital, you can see there are some limitations always there. Like one thing is that the workload is much more higher because most of the patients, those who are coming here, they are physically challenged people. So, suppose I give example, like in our institute, we are performing in cancer centers around 1,500 major oncosurgeries per year. But in compared to that, we are doing only high-tech 50 to 60 cases. So means that is 3.5 to 5%. So what is the problem here? Why we are unable to do? Because that is number one is the new technology which is coming gradually, and it is the inherent problem in Asian country to adapt the new things, new technology very slowly. Because they see this thing, because that hype we know that last 2-3 decades, that is in the Western country, particularly in the Europe, North America. But in India, that is only just for the couple of years, like last 6-7 years, that is growing up. So what is the problem? That it is a team management. Because you not only the surgeon, there are other people you require to establish this setup, like onco-anesthesis is required, like extensive, like ICU specialist is required, specialist nurse required. So this is teamwork. So that is a very difficult when the workload is much more high. So it is slightly difficult to establish, particularly for this kind of challenging technique. So that is the thing. And another the small way, like the procurement system in the government hospital. So that is a different way. It takes time to procure the things like this. But on the other hand, what you say, how you overcome? I believe just impossible is an opinion. There is nothing is impossible. If you are dedicated, if you are really passionate to do something, you 100% you can do anything in life. Not only the CRS idea, anything you can do if you really dedicated, if you really want to do. Suppose we have been doing the CRS IP for last 6 years, and already the things, the protocol are established, things are well. We are taking, the scientific machine we are using, and protocol taking from Medikabazaar, we are using this, our kits like this regularly. So nowadays, things are settled. So the challenge from the beginning, any new thing challenge should be in the beginning. But at present, when you settle this thing, when you set up this thing, then things are relatively easier. So now we don't have any kind of problems like this. We are running very smooth with our competent team. Our institute is very active in that. So there is no problem is there. So that is my last thing is there. When there is a will, there is a way. If you want to do, you can do. Because with the high pay, the survival benefit in every aspect of the peritoneal surface malignancy that increase very significantly. So there is no question of lag behind. Should go ahead.
Yeah, thank you, Dr. Ray. I can understand how difficult it is for the government to actually run with all the challenges, but I'm sure people like you make sure that even with the challenges, you are able to do it. My next question is to Dr. Yuvraj. Thank you for joining. Dr. Yuvraj is from Kokilaben. He's the head of HIVEC program out there and the robotic surgery initiative out there. I welcome Dr. Yuvraj. And he is one of those few people in this country I know who is working on writing some research papers on HIVEC. My first question to Dr. Yuvraj on the HIVEC topic is, if you can just touch upon what HIVEC is, can you give some broad concepts about it, and just take it from there. Welcome, Dr. Yuvraj.
Okay, hello. Can you hear me now?
Yes.
Yeah, okay. Thank you so much for giving the opportunity to share my experience with HIVEC. So, you know that this is the instrument what we use it to prevent recurrences in superficial bladder cancer. I mean to say that the bladder cancer mainly broadly divided into superficial and deep. Deep means it's invading into the muscle. So the superficial bladder cancer is typically a recurrent disease, a highly recurrent disease, around 70%. So to prevent these recurrences, we use many agents. So the standard as of now or till now was intravesical BCG, the same thing what we give for tuberculosis. So unfortunately, we have a lot of side effects and complications because of BCG, and also non-availability in many countries, including India. Also, it's intermittently available. So we didn't have any other agent. So the HIVEC came as our a savior. So where we can give this medicine to these patients and prevent recurrences. The benefit is almost to the tune of 60 to 70% decrease in the recurrence rates when we use this thing. So basically, what we are using a chemotherapeutic agent, that is mitomycin, and we put it into the bladder. So generally we do it without heating it, but now we have proved beyond doubt in the entire world is that when we give heated mitomycin into the bladder, so that because it is a surface acting agent, it doesn't involve anything in the circulation. So that is the reason. So we heat it to the tune of almost 50 to 52 degrees, and then we give it to the bladder. So that's how it acts, and the results are exciting. Thank you. Anything else you want to know, so let me know.
Yeah. Thank you, Dr. Yuvraj. The time has come for a rotation of the panel. I will start again with you only, Dr. Yuvraj. The lockdown must have been very difficult. So we will continue this topic of HIVEC, and then after this is done, then I'll go to the other panelists so we can finish off the HIVEC part. And I believe you have some cases going on. In case you have to drop off soon, you can.
Okay.
The thing is, I have heard so much praise about this particular procedure from a lot of patients I know. Even international forums I've been hearing about HIVEC. What has been your experience at KDH? Why do you feel you are so convinced and supporting this particular treatment modality and the invention of the HIVEC so much? What do you think is the future for HIVEC in India, and why hospitals, the CEOs and the owners of the hospitals are listening to us, why they should be looking at considering HIVEC in their setup? Why should they do it?
Yeah, it's a very long question, Akash. I think you would have, bifurcated questions, because by the time I answer all these issues, it will be, I may forget one or two. So mainly as clinicians, what we look into that, especially in cancer, two things. One is that we have to give a good control of cancer to the patients. Number two, we look at the side effects should be minimal side effects. That's what we want to do it. But in unfortunately bladder cancer, so almost 75% of the bladder cancer comes and meet us in a superficial stage, where recurrences are really bothersome and they may progress into deeper invasion if you don't treat it properly. In this situation, we used to use BCG, which is a very cheap agent. But unfortunately, as I told you earlier, so it has got lots of side effects. So it was effective, but lots of side effects. And the third problem is the not availability of this drug. So the mitomycin came. So as I told you, so now I am using this one this last almost 2.5 years. We have finished almost 30 patients now, and we have sent this publication to Urology International Journal now. So now, what is the main thing which I observed? Number one, out of 25 patients, only one patient has one low-grade recurrence. So actually, it was initially to start with a high grade. Now it is a low-grade recurrence. We don't bother about it. So apart from that, 24 patients are doing well. Short-term follow-up, very, very short, 2 years is not a big follow-up. but still we are very happy because generally recurrences happens in within 2 to 3 years. And second thing, most important thing, what I felt was that the side effects. Not even one patient we have stopped the treatment or decreased the dose of these patients. So which is very, very unusual when we use BCG. BCG, hardly we can use complete the dose, hardly we can complete the cycle without breaking the cycle. So because we have to give every week for 6 weeks, so that is highly impossible to do that. So these are the two main things. So we have effectiveness and we have the lesser side effects. The only thing what I always tell you, Akash, also that the main thing is that the cost factor. That is the only thing which weighs a little bit negative towards HIVEC. But anyhow, people now are understanding that the side effects are less. They're going for it, but still, so it's little expensive when compared to BCG. BCG costs around 10,000 rupees per cycle, and this costs around 25,000 rupees a cycle. So I think a time will come where you also reduce the price, and it becomes more and more. Now there are 3 or 4 trials going on, randomized trial that will show more light. I think not only mitomycin, we can use different agents to decrease this thing, and this is one of the most important treatment in future. That's what I believe. Thank you.
Yeah, thank you, Dr. Yuvraj. So, how was your challenge in? How did you mitigate the challenge of lockdown, and on how much compliance in patients, etc. you saw? I will be asking the same questions to Dr. Narendra next. Just briefly, I want to ask Dr. Yuvraj, and then immediately in about a minute, I'll be coming to Dr. Narendra. What was his experience with lockdown?
Lockdowns are naturally it had caused complete disruption in our services, but fortunately our hospital helped cancer department to go on, and all of us cancer surgeons and medical oncologists continue to work. We didn't do any lockdown. However, the patient could not reach our hospital. So 2 patients were on HIVEC. Fortunately, they were stuck here. They could not go back. So they went back after 2 months. So because it's a long treatment, 1.5 month treatment, they were stuck here. And one patient who was from Mumbai took later on. So now, I think it is open up. I think we had a lot of support from your team. I think we didn't have any major issues with the lockdown, except that the patient's flow was less. That's all.
Okay, thank you, Dr. Yuvraj. I'm now coming to Dr. Narendra, and after that,
Can I switch off?
yeah, Dr. Yuvraj, if you have to go and attend a surgery,
Yeah.
please do that. Thank you so much for your time.
Thank you so much, Akash. Okay, all the best.
Dr. Narendra, my question to you is, do you think HIVEC and HIPEC are one innovative aspects though we talk about? There is something else you can talk about, maybe in the field of robotics or something else you would like to add, how the oncology space in this country is changing?
Definitely, the exciting times are ahead for oncology field. As we all know, in majority of the big centers all over India have switched over to robotic surgery. I think Dr. Yuvraj is operating a lot of cases on robotic prosthetic surgeries. It's very really exciting field, and also for the patients, it's very safer, and also they can go back to their work within a short span of period with very small incisions, keyhole surgeries. And also for surgeon, there is complex surgeries can be done with equal results as open surgeries, and in a faster way, and a difficult surgeries within the anatomical constraints we can achieve it. So similarly, there are other technologies like near infrared fluorescence imaging, which is also coming in a big way, which again helps in either open or laparoscopic or robotic surgeries. It helps a lot. For example, in a gynecological surgery, if you are operating close to ureter, this imaging can help you to identify the ureter. Similarly, in biliary surgeries, it can help you understand the complex anatomy of the biliary system. And particularly in oncology, it helps in sentinel node identification without any risk of radioactivity, as well as it also helps in knowing the perfusion of various organs. For example, if you are doing a resection and anastomosis of the intestine for a cancer, then we can know whether those intestinal parts are viable or not. Similarly, if you are raising a reconstructive, as a part of reconstructive surgery, if you are raising a flap, you can know the vascularity of the flap, and also it helps in workup of the lymphedema. Similarly, other technologies, I would put it as there is a what is called as a magnetic tracer-based sentinel node mapping, which is coming in recent times, and intraoperative radiotherapy as well as proton beam radiotherapy are newer modalities of treating cancer. So that's how I look at it, Akash.
Yeah, thank you, Dr. Narendra. So we are discussing, for the audience's sake, we are discussing newer modalities in the field of oncology. Now I'm coming to Dr. MD Ray. I love to ask Dr. MD Ray about the administrative aspects of various fields because he works in the government setup. I know Dr. MD Ray has trained many surgeons and many people, especially when they're starting a new setup and all. He definitely helps them out and makes them learn that. I would like Dr. MD Ray to just share some of his experiences running HIPEC on a positive note in center, and how his experience has been in training newer setups, so that this particular program comes in ahead much faster. Dr. MD Ray, please.
Thank you, Dr. Akash, because the training is the one of the most important parts of before to run a HIPEC. Because that HIPEC is a challenging and a complex procedure. So not like a simple procedure like you do only the colectomy, only the splenectomy, only the gastrectomy. So you have to know, you have to well pass through all the procedure, even the peritoneal, diaphragmatic resection, all kind of things. So this kind of hypertension, you need some kind of training. Unless you have some training, so really you cannot do this kind of surgery, and you cannot really just do the justice for the patient. So I get example. So many people like they, without having trained, they are also trying to do CRS hyping like this. But being a part of Premier Institute, I always see when I reopen the case, I can't believe like this people who do this kind of surgery. Even they have written all the things, they have done this omentectomy, they have done this dissection, LV dissection, detuberon dissection, but practically the things are not there. So this is a very unfortunate part. One has the training and then do the proper surgery. Until only do the perfect surgery, so there is no role of doing the high pain. Surgery is the mainstay before high pain. So that's why this term is called CRS. So recently, not recently, but 2 years back, only 2018, there is Chicago consensus. When you can say somebody is 10 for doing CRS and high pain, like minimum you have to observe 20 cases and 5 will be peritoneectomy, 5 diaphragmatic stick dissection, and totally you have to well versed with the chemotherapy, with the equipments, minimum 5 cases. Then you can go for the CRS and high pain. So it's kind of complete training is required to do or to start the CRS and high pain. Without training, that is practically not to be done.
Thank you, Dr. Ray. It was very insightful. It's another high when you train people and a new department is set up because of your efforts, even when it may not be related to your hospital, but as an industry as a whole, or for the sake of the entire specialty and the patients as a whole. People, this particular skill is propagated thanks to you and people like you, that such skills are propagated further. My next question is to Dr. Robin. Dr. Robin, thank you so much for joining us. He was busy in his surgery and he actually came and joined us. Dr. Robin is a GI oncosurgeon from Tata Memorial, and it's an honor to have him here. Welcome, Dr. Robin. I have some questions to ask you. Can you hear me? Dr. Robin, can you hear me? I think his connection got dropped out. My next question is to Dr. Narendra. Dr. Narendra, what is the future looking like at SDIMS? What kind of department setup are you looking at setting up for HIPEC. I believe you have already done some cases with help of Medikabazaar before, and you're keen on extending that program out there. What convinced you to do it, and what is the future which you think at SPIMS for HIPEC?
Just before our conference, I think we with Medikabazaar, with the cooperation of the Medikabazaar, we wanted to start in a big way. But to our bad luck, the lockdown came, and it really, contrary to what Dr. Yuvraj told, it really affected our cancer care, because one of our hospital was taken over as COVID hospital, and many of our resources were diverted due to the overwhelming demand there. Hence, again, from here we want to take it up. Anyway, with the help of Medikabazaar, we are able to start the program, and anyway, nice package we have worked out, and we will be starting soon. Yeah, Dr. Akash.
Yeah, thanks. Dr. Robin, it seems, can't join because of poor network in his operation theater, but I believe he had something exciting. He had something exciting to share, even show the machines, etc., how it was working, but there is some network issue out there. This was an amazing, interesting session to have discussed what the newer modalities are. Are there any questions which we can take now? The CII forum, are there any questions you would like to share with us from the Facebook live feed or anything? Are there any questions which can be forwarded? Else, if there are any concluding comments from the team out here, we can use that and then conclude the session. Yes.
So I can say, like any tool that passes in 3 phases, First, anything tool that is being ridiculed. Second is it is violently opposed. And third, it is a evidence, like being a self-evidence. So like I think HIPEC has entered into the 3rd phase.
Okay.
What I believe personally.
Okay.
And that is the challenge is there. HIPEC is a challenge because there much morbidity, mortality is there. But nowadays with the advent of technology, with the experience, with the training, that has come down. So as per the latest, 8% mortality was there, 20 to 40% morbidity was there in the HIPEC. But in our setup, at present, the mortality rate is less than 2% and morbidity is less than 20%. So on the passage of time, we achieve this one. So I always believe never don't limit your challenges. Rather, challenge your limit. So that always I believe in that. So we can do this thing and better for the patient.
Okay, I'm getting some questions from audiences. Somebody who has messaged me. The question is how easy it is to use HIPEC or HIVEC. If Dr. MD Ray can talk about it, how easy it is, how the general surgeons, if they want to upgrade their skills, and those who have not actually used it before, how easy it is for the surgeons to use it. And the second question is, what kind of surgeons or specialists can actually look at upgrading the skill into HIPEC?
So as per the rule, you have to be a surgeon and you have to be trained in that field, because HIPEC, before HIPEC, the surgery is the mainstay. Because until you do the complete surgery, that is called CRS, cytoreductive surgery. You have to remove all the disease. Like, only the decade back or the decade and a half back, that this kind of disease used to be considered as a terminal disease. Till many centers in the city, also metropolitan city, they also consider this is a terminal kind of disease because peritoneal metastasis is there, like in the stomach cancer, like in the ovarian cancer, colorectal cancer. So that is the normal thing is that it is a terminal incurable disease. So disease, if you remove the disease, you have to be trained in that, because total removal of the peritoneum, starting from the diaphragm to the pelvis, so you have to take some training. So that is very important thing. So unless you undergo some training, it is really difficult to perform the surgery. HIPEC in technically is very easier. So that is nothing. Then you put a machine like this and both way you can put the chemotherapy inside the abdominal cavity with the temperature. So that is easy to learn like this way. But the surgery is really difficult. Unless you undergo some kind of training for this CRS, it is really difficult to perform in the proper surgery. So people can say, I did the surgery, but I don't believe, because in the Premier Institute, I see this, the patient being referred here, what kind of surgery being done here and there. That is very unfortunate. But that anybody can do, any surgeon is a skilled person who can undergo the training. I already told minimum 20 surgery you have to observe. They have to observe the peritoneectomy procedure, so they can do this thing. So that is not impossible. I say only the impossible is just an opinion, not a absolute thing.
Yeah, thank you. Dr. Ninad is not here, but he was regularly in touch with me to actually set up a HIPEC training program for interested surgeons in Mumbai.
Dr. Akash, just to add to what Dr. Ray had told, so there are various training courses conducted by institutes like AIMS, as well as various professional bodies like Indian Society of Surgical Oncology. So many bodies are there. They regularly conduct these courses. So where people can go and get trained. Even AIMS conducts cadaveric workshop where they get an opportunity to enhance their skills, and later they can go to visit some of the centers and get trained. And even if they purchase equipment, doctors, I think Medikabazaar also sends them for training to high volume centers.
Yes,
So it
yes,
should not be a issue. So, but it has to be taken up by the hospitals, and doctors should be trained, of course,
yes,
definitely.
yes. Actually, Medikabazaar does that whenever they buy machines from Medikabazaar, HIPEC, etc. Medikabazaar actually coordinates with all such centers to send them for training if they need it, and we handhold these doctors pretty well, so that they are pretty confident when they're using it if they buy the machines from Medikabazaar.
And even for the initial cases, you can do a proctor based. You can bring a expert. You can to
Yes.
the center, and you can definitely train the local people. So it's not an issue.
Yeah, and if the cost is an issue, Medikabazaar also supports in terms of giving the kits and everything at low cost. If it is for say clinical research purpose or trial purpose, or it is for poor patients and all that. So even they help considering large volumes, and also I think it's a great win-win situation when it comes to propagating these newer modalities in oncology. So, is there anything as a last concluding thing, Dr. Narendra, you would like to add? What has been your experience, etc. So this will be the last concluding sessions now.
Yeah, definitely. We are grateful to Medikabazaar who have agreed to offer their machine on whatever rental basis or whatever. So we are looking at an exciting ways ahead. So there is a lot of patient load in this area, because most of the times these patients are referred to medical oncologists for IV chemotherapy. Intravenous chemotherapy will never reach these tumors because of the low perfusion of these tumors. So it needs a special kind of treatment such as HIPEC. So otherwise, these patients, their quality of life will be terrible, will be miserable, because they will have a bloated abdomen and they will not be able to take proper food. Nutritionally, they get depleted. So a lot of issues are there, and there is a considerable burden on the society as well. So definitely in a place like Tirupati, definitely it's a great opportunity, and we will be the first center to host this. Yeah. Thank you,
Thank you,
Dr.
Dr.
Akash. Yeah.
Narendra. Dr. Ray, do you have anything to add as a concluding?
Thank you very much, Medikabazaar, because they are also supporting us. Like we are doing also kind of research. They are also giving some consideration rate and considerable rate on the providing these HIPEC sets, and they are very much coordinated. And that is a good thing. And HIPEC and CRS HIPEC is, I always say, that may be a challenging surgery, but not impossible, because you have to be dedicated and you have to work on body, mind, and soul. So definitely, we can do the better work.
Thank you so much, Dr. Ray, Dr. Narendra, Joy, and CII platform, where they are actually propagating different things in the healthcare topics to their audiences. Confederation of Indian Industries is an amazing platform because of which we can reach out to a larger audience. Thank you so much, Swapnil and his team out there who have conducted this event today. And I just want to add one last thought of mine. I know so many people who, before such interesting, innovative technologies like HIPEC or HIVEC. I remember they didn't have any other option other than, say, the radical surgeries, and that used to affect their life, quality of life too much. Especially for HIVEC, I've seen it's such a small device. I'm not a surgeon, but it's so easy that even I can use it. It is so easy to use. And it's an automatic thing. You just put it on the patient and it does the thing on its own. And in an hour's time, that entire cycle is complete, painless. The patient sleeps, unlike a BCG treatment where I've seen for my relatives or friends, etc., who had to undergo the procedure where it was extremely painful. And though the cost could be a problem for few people, though it's not exorbitantly priced, but with insurance and all, people who mitigate these costs, a lot of people are able to afford it, though it's not too costly, but it's not as cheap as a BCG. It's a boon for hospitals to do something where a surgeon, say the doctor is able to look at more patients, while the nurse and all can just do this automatically with that HIVEC machine. These things are radically changing the scenario how it is done, and I thank Dr. Narendra and Dr. Ray, Dr. Robin, Dr. Ninad, Dr. Yuvraj to have come, has been the esteemed panel out here, and thanks Joy for this opportunity. Thank you all. Over to you, CI. Thank you.
So thank you all the panelists for joining us and all the participants for joining this event. It was really a thought-provoking discussion. Thank you all the panelists and all the attendees. We look forward for your participation in our future events as well. Thank you.